right, so now time is 1 minute past 6, so maybe we can get started. Hello, everyone. Welcome again to our research seminars delivered to you by the Project TIPCAD. And tonight, so this is our second seminar, and also on Saturday, we had our symposium on dementia in China, Hong Kong, and global context. And following on that, tonight we have a very exciting program aligned, focusing on the drug prescription and non-pharmacological intervention use in China. And we have two very close friends presenting to us tonight. Oh, first of all, let me introduce myself. I'm Dr. Gloria Wong from the Department of Social Work and Social Administration, and also the project coordinator of the TIPCAD project. And so I'm really delighted and honored to present to you our first speaker tonight, Mr. Yingyang Zhang. So Yingyang is currently a Ph.D. student from the Department of Social Work and Social Administration, the University of Hong Kong, and his interests focus on healthcare utilization, such as the potentially preventable hospitalization and readmissions among people living with dementia. And he has been working on a topic associated with the projection for multiple long-term conditions and the corresponding healthcare utilization and cost among these vulnerable population using electronic medical records from public hospitals in Hong Kong. And this topic is part of the project TIPCAD, and he has currently published, before he has graduated, 2 papers associated with mental health in the Journal of the American Medical Directors Association and the Journal of Affective Disorders. So although Yingyang has done a lot of work on the TIPCAD project and also on various populations. Tonight, I understand that Yingyang will be presenting on yet another project from mainland China. So without further ado, may I pass the time to Yingyang for your presentation?
Oh, okay, thank you. Thank you, Gloria. Can you guys see the slides?
Yes, perfect.
Okay, thank you. Thank Gloria. Thanks. Thank you very much for the invitation. And before this presentation, I want to take this opportunity to thank the generous support from colleagues in TIPCAD. And the topic I'm gonna present is prescription patterns of antidementia and psychotropic drugs in people living with dementia. Findings from the clinical pathway study of Alzheimer's disease in China. Pharmacological treatments for people living with dementia targeted for improving cognition and managing behavioral symptoms should be available to people living with dementia. Currently, the first-line agents included cholinesterase inhibitors and memantine. And cholinesterase inhibitors were licensed for mild Alzheimer's disease. It can ameliorate cognition and global functioning. And it's a combination of cholinesterase inhibitor plus memantine can treat a moderate to severe Alzheimer's disease. As they can also improve cognitive, functional, and global symptoms. And there is another category of drugs, which is called psychotropic drugs, including antipsychotics, anxiolytics, hypnotics, or sedatives, antidepressants, and anti-epileptics. Currently, some literature shows that its efficacy in improving neuropsychiatric symptoms is very limited. And such kind of drugs also have side effects, including increased risks of adverse cerebral vascular events, falls, and occult mortality. Therefore, a lot of dementia guidelines recommend that psychotropic drugs should only be prescribed for people living with dementia at risk of self-harm or threatening others, and those with severe neuropsychiatric symptoms generating grievous distress. In addition, the co-prescription of psychotropic and antidementia drugs also has some side effects, such as reduced potency and early discontinuation of cholinesterase inhibitors therapy among people living with dementia. Therefore, dementia guidelines also recommend that co-prescription of these drugs should be used cautiously in line with the best practice standards. And currently, the evidence about the pharmacological treatment of dementia in China is lacking, and no research has investigated co-prescription of the two drugs, I mean, psychotropic and antidementia drugs, in a single study of factors associated with prescription patterns in China. Therefore, in this study, we aimed to address this research gap using data covering a wide geographic area in mainland China. Well, let's move on to the methods part. The data we used were from the clinical pathway of Alzheimer's disease study, and the data were collected from 28 memory clinics at tertiary hospitals across 14 provinces. And in this study, actually, it is an 8-week multi-center registry study conducted between November 12, 2012 and January 31st, 2013. And this is the flowchart of study population section. I'm sorry, it looks very small, but the key message is that we got participation with possible dementia, and then during the 8-week follow-up, there were 3 assessments about the clinical information of people with possible dementia. And then we got individuals aged 45 years willing to attend a 2-month follow-up interval and accompanied by an informant carrier. These people were eligible to enter our study. And then we got 751 patients with a confirmed dementia diagnosis during the 2-month course. After excluding the missing values, we got 694 participants for the regression analysis. Measures, the main outcomes of interest include prescription of cholinesterase inhibitors, memantine, both cholinesterase inhibitors and memantine, and both antidementia and psychotropic drugs. The secondary outcomes of interest include prescription of any anti-psychotic and any antidepressants. The coding of prescription of antidementia and psychotropic drugs were based on the WHO ATC classification. The reason why we use this this method to classify the drugs is that we want to compare our results with this in other countries or areas. The explanatory variables include age, sex, whether the current visit was the patient's first consultation due to cognitive impairment, functional status, dementia subtype, dementia severity, and neuropsychiatric symptoms at the first recording of a confirmed dementia diagnosis. We firstly tabulated sample characteristics at baseline, and then we reported the prevalence of antidementia and psychotropic drug prescriptions. And then we fitted logistic regression models to examine factors associated with prescription of cholinesterase inhibitors, memantine, and their combination. And the concomitant prescription of antidementia and psychotropic drugs, and prescription of antipsychotics and antidepressants. This device method was used to deal with the missing value, missing values. And we also used the buffer running correction method to solve the problem of inflated type 1 errors, since we got 6 outcomes in this study. Let's move on to the results part. And this table shows the baseline sample characteristics. And we can find that half of them were female respondents, and the mean age was 73 years. And almost 30% of them had their first consultation due to cognitive impairments. And most of them had Alzheimer's disease diagnosis. And around 45% of them had moderate dementia. And around 46% of them needed help with instrumental activities. And half of them had agitation and neuropsychiatric symptom. Just less than 7% of them received the training for dementia care. This table shows the prescribing patterns of antidementia and psychotropic drugs. According to this table, we can find that half of them had cholinesterase inhibitors prescription, and 39.9% had memantine prescription. So in total, the prescription rate of any anti-dementia drugs was 77.8%. Let's move on to the psychotropic drugs, and we can find that 33% of them had antipsychotic drug prescription, and a quarter of them had the co-prescription of anti-dementia drugs and psychotic drugs. This table shows the logistic regression analysis of the prescription of anti-dementia and psychotropic drugs. In the model 1, the outcome was cholinesterase inhibitors. We can find that patients living with vascular dementia and frontotemporal dementia, and those with living with psychotic symptoms had lower odds of being prescribed cholinesterase inhibitors. In the model 2, the outcome was memantine. And so we can find that patients living with frontotemporal dementia had almost 10 times odds of being prescribed memantine, and patients with severe dementia had around 4 times the odds of being prescribed memantine. And in model 3, the outcome was the prescription of cholinesterase inhibitors and memantine. We can find that severity of dementia had a very strong significant association with the co-prescription of these 2 drugs. And in the model 4, the outcome was the antidementia and psychotropic drugs. we can find that neuropsychiatric symptoms had a significant association with the prescription of antidementia and psychotropic drugs. Like psychotropic symptoms, agitation, and depressive symptoms had a significant association with being prescribed, co-prescribed antidementia and psychotropic drugs. Well, this is the last table. It shows the logistical regression results for prescription of antipsychotic and antidepressants. And in this model, the outcome was the prescription of any antipsychotic. And it shows that patients living with psychotic symptoms had around 4 times as odds of being prescribed antipsychotic. And let's look at this model. The outcome was the prescription of antidepressants, and we can know that patients living with frontotemporal dementia and patients with agitation symptom and depressive symptom had a much higher odds of being prescribed antidepressant. Before making conclusions, I want to have a very quick introduction about the National Dementia Guideline in mainland China. The first National Dementia Guideline was issued by the Chinese Society of Psychiatry in 2007. And in this guideline, it provides knowledge about the diagnosis and treatment of dementia. And then there's another dementia guideline which was published in 2010. It provided recommendations on drug use for Alzheimer's disease and other dementias. However, to what extent clinical practice is consistent with the clinical guidelines remains unknown. Based on the results and the background of dementia guideline, we draw 4 conclusions. The first one is that anti-dementia drug prescription was adequate and generally guideline-oriented in mainland China. I mean, in high-quality hospitals in mainland China. And there's a prescribing rates of psychotic drugs and the co-prescription of anti-dementia and psychotropic drugs in well-established hospitals in mainland China were kept at a low level and maybe even lower than in Western countries. And pharmacotherapy was mainly associated with the clinical characteristics of a patient with dementia and was generally consistent with the Chinese dementia guidelines. Of course, our data are relatively old, yeah, but we provided the baseline evidence for the investigations on changes in prescription patterns. Yeah, and more longitudinal surveys are needed. And yeah, since the time is limited, I couldn't introduce detailed information about the dementia guidelines. And if you are interested in this study, you can download the paper we published in JAMDA. And of course, you can also find the Chinese dementia guidelines. And yes. This is our TIPCAD members. Yeah, that's it.
Thank you so much, Yingyang. Very on time, which is good because that leaves us some time for discussion and questions. So for those of you who want to ask any questions, you can either put them into the chat box or you can unmute yourself. And there will be also time for general discussion and Q&A after the second presentation. While you're doing that, putting in your questions or formulating your questions, I want to add some information about the study because Yingyang, you have already mentioned how unique this data set is, although it's quite, it's a bit old, so it's almost 10 years from now, 10 years ago. But so this is a study led by Professor Gloria Wong from the Peking University Institute of Mental Health. And I think this is the first study that give us some insights into the practice of dementia care in mainland China. Is that right, Yingyang?
Yeah.
And the 28 clinics, I think they are from more established hospitals in mainland China. So that means what you're seeing is a better picture from across all provinces in China, and may not be totally representative of the situation in China. Is that right?
Yeah, exactly. Since the data were just collected from tertiary hospitals in mainland China, and actually they are pretty they are high quality public hospitals. We couldn't make the same conclusion in like some other hospitals.
Yeah, but so although it's a little bit dated and it's already representing the best situation in mainland China 10 years ago. So with the development in the past 10 years, what we would hope to find out maybe later on with a follow-up study is whether the best practice has been extended to other parts of China and whether there's any improvement. And so for those of you who have joined us in the first seminar last week and also on the symposium last Saturday, our researchers and also Professor Gloria Wong shared with us, first of all, the research situation in terms of drug and non-pharmacological interventions based on published data, which we find actually there is a lot of research going on in terms of intervention and support in Chinese population. However, how that translates into practice, we have only information from this study and also from the symposium on Saturday. We learned about a lot of new initiative, new services developed in mainland China. However, the research is apparently not there yet. So that's why Professor Wong suggests there need more implementation science research. So that may explain why, although this data set is a little bit dated, we can still get it published in just last year. Is that right? So there's a serious lack of information about what's happening in the real world in terms of dementia care with research evidence. So maybe that's a knowledge gap that we can address together. Right, I don't see any questions in the chat box. Let me pause for a minute to see if there's any questions. Anyone want to just unmute themselves? Now, if not, because I think you have more idea about this data set and also the situation in China after listening to our second talk, because our second speaker, Dr. Xinxin, is going to use the same data set to look into the non-pharmacological intervention, prescription and use in mainland China. So let me introduce Dr. Cai. So Dr. Xinxin Cai is currently a postdoctoral fellow in the Research Center for Gerontology and Family Studies, Department of Applied Social Sciences at the Hong Kong Polytechnic University. She obtained her PhD degree from Hong Kong U from the Department of Social Work and Social Administration. And she works on topics in relation to mental health and aging, including very importantly, access to healthcare and social care, and the service use and policies for people living with dementia, people with later life depression, and also family functioning and resilience, and also using longitudinal databases for older adults. And her main area of interest is access to care, and she studied the impact of a task-shifting approach on multidimensional access to care for older adults with depressive symptoms in Hong Kong for her PhD dissertation. I've learned a lot from Xinxin's work in terms of how do we understand access to care. So let me pass the time to you, Xinxin, to share with us what's the situation in terms of access and use of non-pharmacological intervention in mainland China.
Thank you, Gloria. So can everyone hear me? Because I previously have some problem with the equipment. Hope it works now. So let me share my screens.
And we can hear you. So I will let you know if there's further technical issues.
I think if you can hear me now, it's okay. So can anyone share see the screen?
Yes.
Sorry. Yes. So
yes, it's working.
Okay, thanks. Let me start now. So thanks, Gloria, for your introduction, and also inviting me to the symposium to introduce what we have done. And also thank you for Yingyang for your introduction. And since we are using the same data set, I'm very glad that I can pass the details on introducing the data sets. And the work I'm going to present is also in collaboration with Yingyang, and also we receive substantial support from our colleagues and supervisors. And now I would like to briefly introduce, not briefly, very detailedly, introduce the prescription of non-pharmacological interventions in memory clinics in China using the same data set introduced by Yingyang just now. First, a little bit background. We all know that we are facing increasing number of persons living with dementia. Worldwide, the number will be triple from about 2020 to 2050, which is similar in China. We now have an estimated 15 million of people living with dementia, and by 2050, the number will increase to about 15 million. And besides, we also have about 14 million people living with mild cognitive impairments. And those populations with impairments in cognitive functioning and daily living abilities not only result in greater burden for their family and the society, and also it creates huge economic burden. So, but there is still no disease-modifying treatment for dementia until now, but we still recommend interventions, including like what Yingyang introduced earlier about the drug interventions, and also the non-pharmacological interventions to slow down the deterioration process, and also to improve the functioning, to relieve symptoms and delay institutionalization of people living with dementia. As Yingyang introduced, there are some medications being approved for managing dementia symptoms, but still there are varying differences on their effectiveness and adverse effect. Therefore, non-pharmacological interventions have been recommended a lot. And in WHO's also a file about 10 years ago, where he highlighted dementia as a public health priority. Non-pharmacological interventions indeed has been recommended as a first-line response to dementia. For types of dementia, we have structural and manualized interventions. For example, the cognitive stimulation therapies, which has been improved, have abundant evidence on its effectiveness. Also, we have some unstructured suggestions on lifestyles and behavioral change, like doing exercise or play Tai Chi or Mahjong in Chinese context. And there are a lot of studies reporting the outcomes on using non-pharmacological interventions, which is usually on cognitive and daily functioning, and also quality of life, self-efficacy, and also reducing the neuropsychiatric symptoms or behavioral changes. We can see from a study summarized here, those many types of therapies can all show some effectiveness in improving cognition, ADL, and also the PTSD of people living with dementias. However, while we all know that MPIs will be effective in reducing some symptoms and improving some outcomes, provision, how much it is provided and how it is provided, and also whether there are some determinants influencing the access and obtaining of MPIs remain largely unknown. In the field of access to care, Anderson model is a very wide applied model, which suggested that access is influenced by predisposing characteristics, enabling factors, and also needs. But empirical evidence using this model mainly adopted a user perspective, focusing on individual level factors and neglected the influence of institutional level factors. Therefore, the aim of the current research was to characterize MPIs prescribed to people living with dementia, and also to investigate the factor associated with MPI prescription, considering both user and provider impact. And also, we are going to explore the role of user, carer, and provider in the prescribing process. We choose the prescription as a window to look at this access to care because the prescription is a result of medical consultation, which involves the collaboration and shared decision of users, carers, and providers. Therefore, we got a chance to see what's happening in the process, who is leading the process, and who is declining the services. So the data used in the current study is the same from Yingyang. And in the current sample, we will include 889 community dwelling people diagnosed with MCIs or dementia. The major outcomes of measure is first, the prescription of non-pharmacological interventions, and also the reasons for not being prescribed. The independent variables were selected based on the framework we introduced earlier by Anderson. We include predisposing characteristics, including age, gender, marital status, and carer attitude, and also enabling resources, including education, household income, dementia family history. We also include needs process, including dementia subtype, severity, and also a carer burden. And for the hospital level characteristic, we include the specialty of providing the prescription and also the hospital at the level of the hospital in the dataset. For analysis, we use descriptive analysis, t-test and chi-square test, and also multi-level logistic regression to controlling the hospital level effect. The final result, the final sample, including 889 people with MCI or dementia, among which 86% of them were considered as having an MPI needs judged by the physician. And also there are about 14% of them were considered as do not have an MPI needs. For the total sample, about 1/3 of them were finally prescribed with non-pharmacological interventions. Also, about 70% of them were not prescribed. The mean age of the sample was 72 years old, and also half of them were female. For those who are considering do not have a need for MPIs by the physicians, they were more likely to have lower household income and also have a surgery history. Therefore, some physicians might avoid providing suggestion on the pharmacological interventions. And also, if they were seen by a neurologist and in a comprehensive hospital, then actually they were slightly more unlikely to be provided of non-pharmacological interventions. First, we would like to characterize the prescription of MPIs. We recorded 375 prescriptions, which were categorized into 8 categories. The most common type is cognitive activities, which may include some memory activities, news, words reading and recitation, and also playing chess. And the second most prescribed one is caregiving training and support, including training of family carers, and also some group activities gathering the carers together. And the third most prescribed type is psychological intervention, which including some psychological counseling, cognitive behavior therapies. And as some researchers, some evidence show that multiple prescriptions, multiple use of non-pharmacological interventions simultaneously is actually beneficial to people in need. Therefore, we also recorded the combinations of prescriptions, and indeed we find while multiple prescription is recommended, about 80% of them receiving single intervention prescriptions. And what we can see just now is that many of them were not the manualized or structured interventions, but are sometimes more suggestions on lifestyles. And here's the results of the multi-level logistic regression controlling for hospital level effect. And we find that among all the individual level characteristics we control, there are 4 factors that significantly influence the prescription of non-pharmacological interventions. The first is dementia family history. If a person have a family history of dementia, or he perceives more gains in the process of caregiving, then they are most likely to be prescribed with MPIs. And if they have a war-style relationship, which is very interesting, they will also be more likely to prescribe with MPIs. And for caregiving burden, if the person have lower caregiving burden, then he will be more likely to be prescribed with MPIs. And for this multi-level logistic regression, we recorded the intra-class correlation coefficient, which is as high as 73%, which indicates that for the variants we identify in the current analysis, actually 73% of the variants can be attributed to hospital, which we control for the multi-level influence. And for the 440 respondents who are considering having a need for MPIs but do not receive a prescription, we also recorded their reasons of declining or not receiving the prescription. Actually, over 70% of the reasons were user-led. The most commonly reported reason is the person or carer thought negatively about the effectiveness of MPIs. Seems that they do not have a lot of trust or confidence on MPIs. And also, the second reason was that carer were unable to do or do not have the resources to collaborate with the implementation of the MPIs. Financial constraint is another carer-led reason. For the provider-led reasons, we can find physician thought negatively about the effectiveness of the MPIs. And also, some institutions do not have the relevant facilities or resources to prescribe the MPIs. Those are the user-led reasons. And here's all the results, and I would like to briefly summarize the results and some of our illustration or explanations on the results. As Gloria just mentioned, though the data is a little bit outdated, but still it is the first study describing the prescription patterns of non-pharmacological interventions in memory clinics in a relatively larger sample from middle-income countries. From our results, we see that among the memory clinics, which is already top ranking in China, the MPI prescriptions was still not yet a mainstay of management, just a slightly bit more than 1/3 of the people with MCIs or dementia receiving a prescription. And institutional level factors were considered as, or found as the key determinants of whether people with a need of MPIs receive the prescription or not. We've identified some possible explanation towards this phenomenon. The first is the lack of clinical guidelines and protocols. Yingyang has just mentioned some of the national guidelines or clinical protocols for dementia in medical area. So there are some guidelines, although people may not strictly follow it, but there are some guidelines on prescribing the drugs. But for non-pharmacological intervention, these clinical guidelines and protocols is lacked. And also we see that there are some differences among the prescriptions by different specialties. For example, comparing with neurology, the geriatrics specialty were more likely to prescribe non-pharmacological interventions, though not significant in our data. So we see that for different specialties, there may be some different focuses in management or providing services or different interest, a field of interest. Therefore, people will have, the physicians will have different pattern in describing. And also, there can be variations on service policies, goals, and staff knowledge and resources at institutional level, as reported by some physicians. They will consider like the people has a need for MPIs, but actually the institution is seeking help for may not be able to provide such facilities or resources to deliver the MPIs. And though there are many provider-led reasons, but still there are some individual reasons. While the institution can offer MPIs, but people do not receive it. But we do not find predisposing factors such as needs or such as age, or need factors such as types and severity of dementia predicting prescription. This points to a potential mismatch of service needs and use. And for the individual factors, we find a family history of dementia, more positive gains in caregiving, and also less burden is related to the prescription for dementia. However, we also identify that worse carer relationship are related to prescribing. We have some possible explanation on this, but we can. But the discussion is also open. We welcome any suggestion on explaining this phenomenon. The first is that the carers who are able to acknowledge and report there is a negative relationship, like more resentment and anger during the interaction with the people living with dementia. Actually, they were more like the persons who truly understand and knew the scenarios, so they may be more ready to receive the support services. And the second is that carers may be a representative of the people with MCIs, and we all know that people with MCIs or dementia sometimes show some avoidance on receiving or on acknowledging they have some issues with their functioning or cognition, or avoid to receive either drugs or other interventions. Therefore, the carers with better relationship with the people with dementia may actually decline service in view of the unwillingness of the person. In view of the unwillingness of the person, therefore declining the services. And we've identified that over 70% of the decisions on not prescribing needed and MPIs when needed were made by users. All these findings points to something we need in the future. The first is a prescription guideline and human resources development across specialties and sites, especially for non-pharmacological interventions. The second is that we need carer support and education, not only among the general public, so that PC could get more and easily access information on what is MPIs and whether it is effective to have more trust. Also, during the consultation of the physician with the carer and people living with dementia, the support and education will be very effective. We suggest that could be psychoeducations about the effectiveness of MPIs and some guide to access available resources and instrumental support provided during the consultation, so that people will have better understanding and support for the prescription and use of MPIs. And also we suggest policies to address some potential inequalities. For example, to providing some financial support, incorporating MPIs into the medical insurance catalog. We do find that for the people who were considering do not have a non-pharmacological, do not have a need for the MPIs. Many of them were those less economic, many of them are with less economic status. This could also implying that there are some potential inequities related to financials behind. And there are some limitations of the current studies, which we also want to see more representative, updated longitudinal data in the future. And also, if there could be standardized in the recording and categorizing of MPIs, then our categorization and also typology of MPIs may be more standardized and also more meaningful. And that's all for the presentation. And thank you for coming to this session and listen to the presentation. Also, thank you all for your support and suggestion later.
Thank you so much, Dr. Tsai. So I think we have a few minutes for discussion and questions. Maybe should I invite Yingyang to also join us so that we can have some general overall discussion. Right, as mentioned, feel free to unmute yourself or put your questions in the chat box. And I think you might need a few minutes to do that. So while we're waiting, I do have something to comment on, because I think the two studies complement each other to give us a full picture of the situation of interventions and treatment in people with dementia in China. And one point I noticed is that, so for non-pharmacological intervention, the actual prescription is less than half of the drug prescription. So if I get it correctly, it's around 30 to 40%. Is that correct?
36%, yes.
Yeah, so it's half or less than half of the drug use. So yeah, what do you think? So you name a lot of possible reasons for this low uptake, but I wonder what's your views on that, because it seems to me quite a low uptake.
Okay, so maybe many of my opinions have been introduced earlier, but I may recap a little bit first. I think the leading question is still to at the current stage, the leading problem is still the hospitals and the institutes, more from the provider side, because you see some of the hospital reported that they do not have enough resources or facilities to support the provision. Also, some physicians, they themselves have no confidence on the effectiveness of the MPIs. And I think the education and also training and resources support for physicians is not enough at the stage. Therefore, the drug prescription is still the domaining task for the physicians to provide services. And also, there are many declining. For example, what we can imagine in a real consultation scenarios is that after providing some drugs, the physician may also say, why not you try on what? And the carers and the patients, they may not already do not have enough knowledge on what is MPIs and whether it has effectiveness. And following the drug prescription, they may feel a little bit burdensome or too much unclear, unknown terms coming to them, which also impeded them from using of MPIs.
Yeah, and yeah, that's a good point about education for service providers, because that reminds me of a recent experience, also made possible by Professor Wang. So you mentioned, Xinxin, in your talk that CST, cognitive stimulation therapy, is already a recommended intervention in other parts of the world. In mainland China, so Professor Wang is very interested in introducing this to mainland China more systematically. So she invited me to lead the training, and over a few months of time, we trained over 100 of professionals from different parts of China, and they are multidisciplinary teams. So teams made up of clinicians as well as other like health workers, so, and counselor. So and from that experience, that was in 2020. From that experience, I realized that for many of them, non-pharmacological intervention and understanding theories behind and the evidence on its effectiveness is something quite new to many of them. So I think, yeah, as we mentioned, although the data set is a little bit dated, but I guess especially in terms of the non-pharmacological support, social support, psychosocial support, is somewhere that is probably has a lot of mileage in Chinese population. And also Professor Huang in the seminar at the symposium on Saturday, she mentioned this new initiative of social prescribing in China. And I think that is something quite encouraging. And as for the pharmacological side, Yingyang, you look into, so that is a really rich data set. You look into all sorts of Western medicine, and from our earlier meta-analysis, we noticed that in a lot of research done in Chinese population, traditional Chinese medicine is actually quite popularly researched on. I'm not sure if in the data set you have information about traditional Chinese medicine prescription.
Yeah, indeed, we used the WHO ADC method to extract the Chinese medicine called ginkgo. Yeah. Actually, as a prescription rate of ginkgo was around 6%. But after reading some literature from Germany, we found that actually the prescription rate of ginkgo was pretty high. Yeah, I think it's interesting.
Yeah, that's very interesting because based on Western literature, this is actually currently not recommended, but we are only able to look into the effectiveness of all these different interventions in Chinese population from our study. So maybe later on we'll be able to see a lot more the effectiveness of different interventions in Chinese population, and that may feed back to what Xinxin you have mentioned. Perhaps we need some kind of guidelines specifically targeting Chinese population. So like in the UK, they have the NICE guideline telling us what is the first line of intervention in terms of drug and non-drug treatment. But maybe we need something that is specifically for Chinese, so that we could aim to increase the access to both drug and non-drug interventions. Right. And I noticed in the chat box, I'm not sure if Xinxin or Yingyang, you have any information on that, but we have a question about what is the current situation with primary care prescribing. So instead of in hospitals, whether primary care in mainland China doing anything about the use of drug treatment and also non-pharmacological intervention, or whether hospitals are still the main prescribers. I wonder if you have any ideas about this.
I may not say from a very evidence-based, but only my observations on mainland China. But I think primary care in mainland China, to some degree, shows a different role in Hong Kong and in other countries, because the hospitals in mainland China are more there are different levels, level 1, level 3, level 2, and most of them are very accessible. So you just lie there or go there and do not need a booking, or either you make a booking just very recent days, you will get access to it. So I think people still go for those health problems, especially with some misunderstandings or less awareness. They still turn to hospitals for health. And the primary care were indeed very primary, like providing some very basic diagnosis or treatment, like for a cold, for a fever, and in primary care. So I'm not sure whether there are more better evidence, and I believe there will be some, but I think from my observation, the treatment and diagnosis in dementia mainly happens in hospitals, but not in primary care.
Yingyang, you have anything to supplement?
I actually, I'm not very good at the knowledge of knowledge about the health system in mainland China. But according to my own experience, I know that actually patients patients living with dementia or their family carers actually can buy medicine via e-commerce platform like Jingdong in mainland China. Of course, they need the doctor's prescription. Yes, so for the question, our hospitals are still more likely to be the main prescribers. Actually, since I don't have such kind of data, yeah, so I can't answer this question. Yeah.
Yeah, don't worry. No, I think what both you and Xinxin's impression is also my impression. And I think as we keep mentioning, this study, the clinical pathway for Alzheimer's disease is done exactly because of the lack of information about the current situation in terms of prescription, in terms of practices in mainland China. And I don't think there is I am not aware of other information available that tell us more systematically what is the current situation. But that's a very good question. And this is exactly what we are trying to find out more, because we can have a lot of research evidence, but how that translates into real world practice is something that we need to learn more about. So, yeah, thank you so much both. And we have another questions from Dr. Pion Leung about whether people who did not wish to participate in receiving non-pharmacological intervention is because of lack of evidence base of these interventions. So yeah, what's in your view? Whether it is because there's no evidence or because you said there may simply be a lack of awareness of the evidence.
I think in CPAD team earlier, Dr. Shi have done a meta-analysis on the effectiveness of intervention of dementia in China, but sort of I forgot whether it including some non-pharmacological interventions. Yes, including.
It covers everything.
So, therefore, so actually we have evidence for those non-pharmacological interventions. I think it's still in the process of developing, because I think some kind of the treatment of dementia in China still have a lot of space to improve. But I think even there is evidence-based interventions, it is still important to let people know about these interventions and let physicians to get to know aware and get to know how to master these interventions. And then people should have the trust and should be aware of and should have a trust on these evidences. So it's still a long way to go. We have evidence-based in China, evidence-based interventions in China, but we need to develop more evidence, and we need to do more promotions and also the trainings and raising of awareness.
Yeah, indeed. So that's also what I'm thinking, because that reminds me of the meta-analysis. The main finding is that any intervention is better than usual care in Chinese communities. Although we have to be cautious because the quality of the evidence is still on the low side. But I'm very confident that if we can have better and more research in Chinese population, we'll be able to build up that evidence base to support more rational and informed clinical guidelines. Right, and I think so. We have one more comments from the same participant. He said non-pharmacological interventions are somewhat naturally inherent in Chinese culture. Yeah, probably it's just a issue with data, but also I think Xinxin also mentioned another possibility is because the hospitals, they do not have knowledge or access to who is providing these non-pharmacological interventions in the community. For example, cognitive stimulation or physical exercise opportunities. So that's also talk to the need of communication between social service providers and also hospital-based services and clinicians. So maybe that's another area that we need to work on further. And with TIPCAD, our experience from Hong Kong, actually we would be looking for sharing our experience with the greater Chinese communities. Right, I thank you very much, everyone, for joining us tonight. And I noticed that time is now 1 minute past 7. So I will try to stop here and a reminder, so tomorrow we will have another and our last research seminar from TIPCAD this month, so do join us if possible, because we will be looking into another very interesting area, which is about cause of dementia, and we will have Dr. Mr. Yingyang Zhang and also Dr. Cheng Shi sharing with us. Okay, so thank you so much, Xinxin and Yingyang, and also everyone in the audience. Good night.
Good night. Thank you, Gloria. Thank you, Yingyang.
Bye-bye.
Bye.
Thank you, guys. Bye.